spontaneous as possible. It's science, so I'm going to have to bore you a little bit. So we'll start with turning off the cell phones and opening the ears and the minds and getting into some science of recovery. So all of yesterday afternoon, for those of you who were here, and today, this morning, this afternoon, we wrote really inspiring stories and people's visions and leadership of what recovery-oriented systems of care are going to be. And of course, we need some empirical basis for building the science of recovery and the services of recovery, or elucidating the phenomenon in order to maximize how helpful all of the investments we make in terms of services and other community resources are. So, under the leadership and vision of Dr. Laudet, who I want to thank, and Irada in general, in preparation for this conference and for the brief that's in your packets, we called a number of stakeholder groups, perhaps not every stakeholder groups, but we called the recovery community through the enormous help of Pat Keller, who gave us many of the issues and concerns that the recovery community wants to find out, things that they want to see research can address. We asked providers throughout the country, people from different funding sources, different treatment modalities, city sizes and all that, about their vision for recovery, what they perceive to be obstacles, what they want research to answer, and of course I asked some of my colleagues, researchers as well. And this produced a very long list of questions, which is somewhat detailed in the appendix of your brief, and that I'm going to summarize for you today here. So the first thing is, why do we need a science of recovery? There's been millions and billions of taxpayers' money that have been invested in NIDA, in NIAAA, and other former sources. And the taxpayer probably thinks we know quite a bit about the entire process. And in a way we do. We know a tremendous amount about the etiology of addiction. We know patterns of active addiction, like these short-term patterns. We know some of the predictors of people using drugs and people not using drugs. And we can go on the web very easily nowadays, and with a few clicks of a mouse we can get something like this and double-click on any of these links and produce very detailed reports about by age, by geography, by marital status, by drug in the past month, in the past year, and all of that. Now, if I ask you these questions, and the press occasionally asks me these questions, how many people in the US are in long-term recovery? I don't know. What is long-term recovery? I'm not sure. Is it 5 years? Is it 10 years? Is it 7? I don't know. How do people get into long-term recovery? I'm not sure. We have some ideas, but we don't really have the science behind it. Bill mentioned this morning that treatment works, and there are evidence that at least in the short term it reduces substance use for people. It reduces some of the social consequences of substance use. But he also mentioned, and Dr. Clark mentioned also, that very few of the people who actually need help ever seek it in their lifetime. So how do we sell services? So far we've been selling abstinence. We haven't done a very good job. People aren't coming to our doors. Bob just mentioned that medications are being developed and tested, and medications seem to be successful at helping people curb cravings and use less. So are we curing addiction? I mean, if we look at diabetes, we find medication and we consider that we may not have a cure, but we really have something to really manage the illness. So have we reached that point in terms of addiction? Now, addiction, from all that we've been able to learn from it, from these volumes of science, is a chronic condition, which means that it can be managed, the symptoms can be managed, it can be arrested, but it can be cured. The primary symptom, of course, is drug and or alcohol use, and the secondary symptoms or consequences are the laundry list that Dr. Clark showed before, which is homelessness, bankruptcy, legal problems, family problems, mental, physical health, and all that. And we have the added category in our disease, as Bob just called it, which is jeopardizing public health and safety. Other diseases, such as diabetes, one could argue, have enormous public health consequences as well, but we also have the safety issue. Dr. Clark gave the example of somebody knocking him down and taking money from him. You don't usually hear that happen from someone because of their diabetes, and they'll knock somebody down to take their wallet. So addiction is a chronic condition on par with other conditions, but it's not exactly like diabetes. It has some unique features because of all of the psychosocial consequences that it has, and also because when people emerge from active addiction, unlike other diseases such as oncology, where people are 5 years symptom-free and they're considered in remission, and they may have, of course, psychological sequelae of their disease, but in our disease, people are still kind of labeled, and they're carrying a bullet behind them of stigma, discrimination, in addition to shame, guilt, in relationship with their family, in relationship to some crimes that they have committed. So all of that tells us that addiction has some similarities with the other chronic conditions, but it also has some unique features, and we're not exactly sure what they are right now. But it has huge ramifications for fostering recovery and for recovery-oriented services, which is what we've talked about today. Now, from the data, the little bit of data that we have from individuals in recovery and from panels that have been assembled in the last 18 months, we have some emerging definitions of recovery. The CSAT 2005 National Recovery Summit said, recovery from alcohol and drug problems is a process of change through which an individual achieves abstinence, improved health, wellness, and quality of life. Quality of life is a domain that's becoming more and more important in other biomedical fields. There are thousands of articles every year that are published. There's less than 50 articles on quality of life in addiction that have ever been published. So quality of life for our addicted patients or clients has not been a major concern of ours, and I think it has to become one of the prominent things on our mind and one of our prominent outcomes. The Betty Ford definition is very similar. Recovery from substance dependence is a voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship, which are dimensions from the World Health Organization Quality of Life Instrument. And of course, the most important definition is that of people who are in recovery. They're the real experts as far as I'm concerned. And someone in one of my studies said, my definition of recovery is life, because I didn't have no life before I came into recovery. So this is the only data slide I will show to you today, and it shows that there are things that we know, which is that, do I have a little pointer? I think I do. It shows that, no, but it doesn't work. Okay, it works a little bit. The blue line is quality of life satisfaction. It's one item from the World Health Organization Quality of Life Instrument that says overall, are satisfied with your life. The scale is from 0 to 10. The x-axis on this horizontal line here plots people by their duration of abstinence under 6 months, 6 to 18 months, 18 to 26 months, and over 3 years. What this slide shows to you in a cross-sectional sample is that up to 3 years, quality of life satisfaction increases significantly, after which it stabilizes, but it's fairly high. And stress, which is the major, that's the teal or blue, greenish blue line there, stress decreases tremendously up to 3 years. And the reason why I'm showing you stress is that stress is typically mentioned as one of the key relapse triggers. So it's very important to see what goes on not only with people's quality of life, but with their stress level as well. So what this slide says to me is a couple of things. One is the promise of recovery and the hope of recovery that they talk about in the big book, Into Action, where they say you'll be amazed before it's all over. It does seem to be a reality, at least from this sample, which was a sample of underserved people in New York City. And these were people who were some of them were in long-term recovery. But it does show that after 3 years, things seem to stabilize, and some other speakers here today have mentioned late recovery or late-stage relapse, and this is an entire arena that we don't know anything about. So you see it stabilized here. Perhaps if it had gone out to 8 years, it goes back down and stress goes back up. I don't know. We haven't done that kind of research yet. So we know that recovery is a reality. Life gets better, stress goes down, but there's a lot we don't know, particularly after the 3-year mark. So what we know so far, and what this is a quote from Dr. Clark, recovery is more than abstinence from alcohol and drugs. It's about building a full and productive life in the community. Now this is the key point for today. Our treatment systems must reflect and help people achieve this broader understanding of recovery. And this is recovery-oriented systems of care that people do need help, or people recognize that maybe they don't need treatment, but they could get help with something. So the science of recovery is going to give us a destination by defining recovery. It's going to give us driving directions or an itinerary by telling us how to get there. And then it's going to tell us whether we're there yet or not. And that part of it has to do with, once we have a definition of recovery, you know, researchers, we love to put numbers on stuff. So we're going to want to measure recovery. We're going to want to come up with measures of whether somebody is doing well. But it's not so much only to find out whether the person is doing well, it's to find out whether the taxpayers' dollars that are going to promoting this elusive recovery is actually getting the person there. Or if the service or the system of service is failing, where is it failing and what else do we need to do to help the person? So that will be our measures section. As I mentioned before, this research will give us a menu of options that people use and can use and would use to get better, and that will hopefully open the door to people who perhaps are not attracted to the kind of specialty care that we offer today, and it may just enhance the likelihood that people will get better. It will give stakeholders realistic expectations of what recovery looks like and what it looks like at different times, and it will provide milestones in terms of how recovery changes over time, what the needs of the individual and of the community and the family in recovery changes over time. Finally, how do we build the science of recovery? Well, so far we've done the science of addiction. We've done a great deal of it. We've done it very well. And we've had a science of addiction that the model has mirrored the service model, which has been acute care. So we've looked at short-term studies, and we've looked at how we initiate abstinence, not recovery, and we have looked at the symptoms. The main outcome is usually abstinence, or some modification, but some version thereof. We corroborate our findings with urine, saliva, or hair, and we're not going to be able to do that with recovery. We may be able to measure abstinence, but we're not going to be able to take hair samples to tell whether you're in recovery or not. So we're going to have to come up with something else. Now, all of these methods have served us extremely well in terms of elucidating the etiology and the phenomenology of addiction, but because we're held to the same standards when we try to practice the science of recovery, it's become, for us, at least for me, a major obstacle. So what the Beatles said, you all know, all we need is love, and we had all the love and the warm fuzzy, you know, this up to now. Now this is science, so what we need is money. And we need funding. We need funding for research that is going to be specifically earmarked to make wellness the outcome, to adopt a developmental longitudinal approach where we look at people for a long time, because I showed you after 3 years, currently we don't know what happens. So we need funding priorities and funding mechanisms that we can take. I mean, we don't have to do this 200 times, these are extremely expensive studies. But we need to do this a few times, and I'm sorry our New York Commission is gone. We were talking with the Commissioner and Dr. McLennan and Dr. Ruiz and a couple of other people before, and our Commissioner, New York Commissioner, is really committed to doing this science of recovery. And what she said is that she's recruiting other states to volunteer to do this, basically, and to maybe gather some funding and then go maybe for some external funding, but to largely fund this to the best of their ability, about, let's say, 10, 15 states, and to just go out and do this, because we need this science in order to... Dr. Conlon, that doesn't mean we don't want your money, but I just want to say that. But, so if any state in this room is represented that is interested in this effort, you can see me or one of us on the podium later on, and we'll welcome you with open arms and open pockets. We need to develop and use psychometrically sound, multidimensional measures of recovery to find out whether or not we're getting there. And we need to identify and consider the multitude of pathways to recovery and recruit accordingly. And that's it. Thank you very much.